Hello, Chapter 8 is titled Pharmacogenomics, and it's going to be a short chapter. I'm really just introducing you to this newer conversation that's occurring in pharmacology, in which this is the branch of pharmacology that identifies the genetic attributes of an individual that lead to variable responses to drugs. Again, we know that drugs are variable depending on multiple factors, and our genetic makeup is one of those. So some of these slides, we will have very little to discuss outside of the actual slide itself that has already been printed for you. And so please understand that I'm trying to make this chapter as straightforward as possible. Again, pharmacogenomics is the heterogeneity in genetic makeup that we know contributes to many variations in pharmacokinetics. We understand that there's various factors that contribute to specific observable pharmacodynamic differences. And this study, if you will, really came about with the CYP450 enzyme system being identified several years ago. And again, we know that there's differences between poor metabolizers and extensive metabolizers and how that then impacts provider management. So you will have patients that you'll have to consider, is their response to a certain medication due to their genetic makeup, and is that why perhaps they are not able to metabolize that medication the same as what has been sort of determined by the pharmaceutical companies as the standard. Again, I've answered this question in the intro to this chapter, but again, it's really correlating gene expression with a drug's efficacy or toxicity, looking at a more individualized approach to pharmacology. When we look at the physiology of so where did this all take place? Well, this all stemmed from the CYP450 observations and determinations that came out of pharmacology over the last, say, 15 years. So let's just take a step back for a moment. We understand metabolism takes place largely in the liver. There are two phases. We have a phase 1, which is an oxidation, reduction, and hydrolysis reactors phase. It accounts for about 60% of all adverse drug reactions, that first phase of metabolism. Phase 2 is what we call the conjugation reaction. And I'm just mentioning that to you because the CYP450 enzyme system was the first biocatalytic machinery on Earth to be understood. The CYP450s contain an iron porphyrin center that is essential for chemical reactions to occur. The CYPs are essentially located in the endoplasmic reticulum, going back to good old basic pathology here, and also in the mitochondria. And they're essential to metabolism. So again, this is why CYP450 is the hallmark of the conversation we're talking about right now. There are various CYPs, and they are largely hepatic, renal, and intestinal. So again, when we think about metabolism, we're thinking about hepatic, the hepatic system, the intestine, and then the renal system for metabolism as well as excretion. So the role of P-glycoprotein, or PGP, for our pharmacology colleagues who certainly know more about this than we will, is it's a membrane-bound ATP-dependent transport system. And what's important is there's a number of drugs that inhibit or activate both CYP450 and P-GP at the same time. So something classically like grapefruit juice, we know can both inhibit and activate these systems. Excuse me for that. The clinical knowledge of substrates, inhibitors, inducers for each CYP 450 family is going to really help us in predicting potential drug-to-drug interactions, and that's where pharmacology is going. Race, gender, environmental factors, and drugs may all alter the gene expression of individual CYP 450 families and subfamilies. So, for example, we understand that 40% of Asians display drug polymorphism. So, we understand already that almost 50% of Asians will have a different reaction because of their CYP 450 genetic makeup versus other individuals. So, even though there is no specific clinical test to estimate sensitivity or activity of CYP 450 at this point, we are understanding that there are certain individuals from certain regions of the world that are going to have more difficulty. And we'll talk about some of those specifics in later chapters. That's why I'm being brief here. CYP families 1 through 3 have the least affinity for substrates and have the widest genetic variability. They're responsible for almost 80% of phase 1 metabolism drug interactions. And I mentioned what those phase 1 metabolism drug interactions were. That's the oxidation reduction and hydrolysis reactions, and that's about where 60% of all the adverse drug reactions occur, at least. There are those variations of polymorphisms in genetic codes for these CYP enzymes having, again, tremendous clinical importance. And the last two slides include just talking about inhibitors versus inducers of CYP 450 and sort of understanding what's the clinical implications when we have a substrate inhibit CYP 450 enzymes. So if you have a substrate that inhibits CYP 450 enzymes, then the inhibitor may decrease the metabolism of the substrate and generally lead to an increased drug effect. Okay, so when you have patients that say they are extremely sensitive to a drug and you maybe in the back of your head are saying, please, that can't be true. No, it really can be. And again, which I'm trying to make, if nothing else, you understand the individualization of how drugs interact with each person. We can't just look at everybody as a sort of a blank slate. What are the clinical implications when substrates induce CYP 450 enzymes? Well, they're going to have a decreased drug effect as a result. And lastly, what are the clinical implications of pharmacogenomics? Well, let's look at two classics. So one being Coumadin or warfarin. So there is actually a genetic test. It's called CYP2C9/VCORC1. I'm not going to ask you, obviously, any of this. But it tests warfarin, and it basically will say with this genetic variant that I just mentioned, VCORC1, then we can see decreased, let me say it this way. When somebody has this genetic variant, we see a decreased reduction time to INR targets that we're trying to achieve, which would help decrease bleeding. So we know that by testing for this variant, we can sort of tailor the target INR a little bit better and sort of predict what their target INR is going to require on our end. And this is important because there are times with people who are still on Coumadin, and yes, we still have people on Coumadin. Not everybody's on Plavix, aspirin, Brilinta, Xarelto, you know, the newer and the best kind of anticoagulants, antiplatelets. We still have, for various reasons, a lot of patients on Coumadin. And what is the number one issue that we see? Well, especially those of us in gastroenterology, we see bleeding. And we do just have patients who do everything right when it comes to their Coumadin. They get their levels checked, they eat all the right foods, they stay away from all the bad foods, and what do we see? They come in with INRs of 8 and 9 and 10, and they are bleeding. So obviously we would say we'll take them off that drug and choose another agent, but sometimes we can't for various reasons. So again, having an understanding of the genetic component that could be causing, or the variant that could be causing either resistance or increased tolerance to this drug or other drugs is really important. We also see with carbamazepine that we now have FDA labeling recommending testing for the HLA-B I502 allele in patients with Asian ancestry before initiating this drug therapy because of the risk of Stevens-Johnson syndrome, which, as you know, can be life-threatening. Stevens-Johnson syndrome is a critical illness that is probably one of the worst adverse drug reactions we see. And we can also see toxic epidermal necrolysis, which kind of goes in line with the differential for Stevens-Johnson syndrome. So again, another exceedingly adverse drug reaction. So again, just showing you to real-world implications to why the genetic testing is important, and I think where the future of drug therapy is going. Okay, thank you.